Hello, and welcome to BasicstoBrilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the South West Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a Haemareg.
And let's get started on today's topic.
From basics
to brilliance. Okay, hi David, how are you?
Yes, good, thank you.
Great. Today we're going to talk about ITP, which is a really interesting topic. And there's not many podcasts out there on ITP, I discovered when searching on Spotify. So I hope that this is going to be a really useful addition for all of our listeners. But let's start.
Shockingly, you'll probably find that I don't know a lot about it. So yeah, it'll be useful for me as well.
Great. Well, let's just start with the basics then. What is ITP? What does ITP stand for?
So this is one of these that I thought the P stood for purpura. But from what I understand, ITP is just immune thrombocytopenia.
That's right, yeah. So it's immune thrombocytopenia. And do you know how it's mediated or what the pathogenesis is behind ITP?
Autoimmune is what I kind of understand. So sort of antibody mediated. And I know there are some idiopathic ones, and that's about as far as I get.
Yeah, so about 60 to 70% of patients have anti-platelet antibodies in ITP, and the antibodies will bind to the platelet and mark it or opsonize it, mark it for destruction by the spleen and the reticular endothelial system, and essentially lead to the premature destruction of platelets from the circulation in ITP. But probably that's not the whole story, and in full disclaimer, we don't really understand how ITP works, and it's a big focus of research still in terms of allowing us to get better treatments in the future. There's probably an element of T-cell mediated destruction of platelets as well, and other mechanisms that we don't fully understand yet. But in a nutshell, essentially, the immune system is destroying the platelets that are being produced in the correct numbers and the correct function, but are being removed from the circulation prematurely. So how do you think it might present then, David?
So, I mean, naively, I feel like this is a loaded question where I hit the big buzz about bleeding is how I imagine it presents.
Okay, yeah. And what kind of bleeding?
Yeah, so platelet bleeding, I'm not sure how that differentiates itself from sort of, I guess, clotting bleeding, but that's how I imagine the presentation is. Doctor, I've got bleeding gums or something like that.
Yeah, bleeding gums is actually a pretty good example. So essentially, I like to think of bleeding in terms of two different patterns clinically when you take a history and exam. You have bleeding secondary to problems of primary hemostasis, so the formation of that initial hemostatic plug, which is affected by having low platelets. And that typically presents with mucosal bleeding, so GI tract bleeding, vaginal bleeding, so heavy periods, epistaxis, and petechial bleeding into the skin, compared to clotting factor problems and deficiencies like in haemophilia A, where the problem is secondary hemostasis. So it's the formation of fibrin, which then cross-links that initial primary hemostatic plug of platelets. And that, when you have problems with clotting factors, that tends to cause more deep tissue, joint and muscle bleeds. And so in ITP, the type of bleeding pattern that you're going to get, as you say, is a sort of platelet bleeding, so mucosal or mucocutaneous bleeding. But actually, although you're right, you have sort of fallen into the trap, because most people would be quite surprised to know that in ITP, there's actually very little bleeding a lot of the time. And that's probably because the platelets are quite large that are produced, because they're new and they're fresh out of the bone marrow. and they are benefiting. You're still benefiting from sort of first pass circulation of those platelets before they get destroyed by the reticuloendothelial system, and they're sticky and good platelets. And so therefore, actually, the amount of bleeding that we see compared to what you would expect to see perhaps is not as bad. But typically they will still come with gum bleeding or nose bleeding or a petechial rash, and then you'll go on to do a full blood count, and that's how you'll then discover that they have low platelets. So I guess before we talk about investigations in ITP, how would you classify ITP, David, or how would you think about it in your head?
So I guess, I'm kind of reaching for straws and picking up on what you've talked about. You've talked about primary and sort of secondary. So I guess problems that are directly related to the platelets, and then problems that are, caused downstream. I guess that's how I would think about it.
Yeah. Okay. So primary and secondary. So idiopathic immune thrombocytopenia or primary immune thrombocytopenia versus secondary. Secondary is about 20% of ITP and is thought to be autoimmune destruction of the platelets secondary to some other underlying autoimmune disease or an underlying malignancy, which is something you always need to have in the back of your head, particularly for patients over the age of 60. And so that's one way you can think about it, is primary versus secondary. The other way you can think about it is in terms of the time scale of having ITP. So we divide it, and the BSH divides it into 3 different types. You've got acute ITP or newly diagnosed ITP, which is where you've had it for less than 3 months. Persistent, which is where it's between 3 months and a year. And then chronic, which is where you've had it for longer than a year. And that's particularly relevant for later on when we're talking about treatment and looking at what treatments are funded and approved by NICE for different stages in having ITP.
Okay, I guess that doesn't really talk about, severity, does it? It talks about how quickly it happens. So say I'm in the clinic and someone turns up with bleeding gums and I do a full blood count and they've got a platelet count of 8. What am I doing?
Okay, so we need to, I think the key thing here, and one of the big take-home messages from our conversation today, is that ITP is a diagnosis of exclusion. So what I mean by this is you must think of all the other causes of a low platelet count and make sure that you've gone through excluding all of those different causes, because there's no one test that will tell you this is ITP, and that can make it quite difficult to diagnose because you need to be quite sure that you've ruled out other causes, and sometimes that can be difficult. So always start with the thinking about I like to make a list of causes of low platelets in a patient and then go through them when I'm taking my history and examination, which is your first investigations you're going to do. And I like the way Susie Morton in their Blood Education podcast think about low platelets in terms of differentials in an inpatient versus an outpatient. So in an outpatient, you've got things like liver disease, alcohol excess, medications that suppress the bone marrow, for example, methotrexate, hypothyroidism, low B12 folate or iron potentially, although typically iron deficiency causes a raised platelet count. The spleen being enlarged and therefore munching up more of your platelets or having HIV, as well as things like myelodysplasia, so problems of production of platelets in the bone marrow, and things like type 2 von Willebrand's disease. And then you've got your inpatient differentials, which obviously there's no firm line between inpatient and outpatient causes, but things to think about in a more unwell patient are particularly your MAHAs. Do you know what I mean by a MAHA?
No, embarrassingly, I hear it all the time, and I sort of tried to join in this conversation about the MAHA, but it means nothing to me.
Okay, so it stands for a microangiopathic hemolytic anemia, and it's a really important thing that we always consider in any patient with a low platelet count. Essentially, it's a process whereby you have hemolysis and use of platelets, drop of platelets, and the key hallmark feature of all of the MAHAs are fragments, basically, so red cell fragments on a blood film, and they almost.
So this is like a consumptive thing. We're using them up.
Yes, and the key thing is that the red cell fragments are an indicator of badness, basically. And your MAHAs are DIC, TTP, HUS, and atypical HUS. And all of these processes, the platelets are being consumed and the red cells are being broken in the blood vessel itself and causing these fragments on a film. So it's really important that we always think about MAHA and consider it in the back of our mind for any low platelet count, particularly if there's anemia and particularly if there's a raised bilirubin as well. The other thing is consumptive or reactive drops in platelet count. So most of my phone calls when I'm on call as a heme reg are about low platelet counts in patients who are septic. And they may not have a MAHA and DIC with fragments on the blood film and a really low fibrinogen and a high D-dimer, but they still have a consumptive drop in their platelet count as they're being used up in infection and inflammation. And then the other one that you should think about in inpatients in particular is HIT, so heparin-induced thrombocytopenia, as an important potential cause of a low platelet count in inpatients. So you need to think about all of those differentials when you're going through your history and your history and exam. And then the other thing you need to be thinking about is, particularly for ITP, could this be a secondary ITP? So are there any red flags in the history for malignancy? So, your classic malignancy red flags like weight loss, loss of appetite, B symptoms, and also autoimmune disease. Is there a family history of thyroid disease? Does the patient have vitiligo, for example, which might be pointers towards this being a secondary ITP? And you're going to examine the patient, particularly looking for an enlarged spleen, enlarged lymph nodes, and also looking obviously for signs of bleeding, particularly at critical sites like in the eye or the brain. And then the next investigation is going to be your full blood count, which will be why you're even interested in the patient in the first place. And obviously you've got your low platelet count, but also look at the trend. If it's a sudden drop in platelet count, it's unlikely to be chronic liver disease that suddenly caused your platelets to drop. And another indicator is the MPV. Do you know what the MPV is?
I'm thinking hard, and no, I'm coming up with nothing.
It's the mean platelet volume.
Okay.
And it basically allows you to see how large the platelets are or how small they are. And if you have a high platelet turnover due to consumption from either an infection or in ITP, then your platelets will be big and new and sticky. And so you'll have a raised platelet volume. And likewise, if you've got a really low MPV, then it might indicate that you might have something like myelodysplasia or some rare inherited platelet disorder like Wiskott-Aldrich syndrome, for example. And then also look in your full blood count at your MCV, so your mean corpuscular volume of your red cells, so how big your red cells are. Because if you've got a raised MCV, that might push you down the direction of MDS or B12 and folate or alcohol as a cause of your low platelets. And then also look at your other cells. So if you've got a neutropenia as well, then you might be thinking more MDS. Or, as I said before, if you've got an anemia with the low platelets, you might be thinking more about a MAHA, particularly if your patient's not very well. So there's a lot of extra information that be gained from the full blood count other than just the platelet count itself. And then I think the next really important investigation is the blood film, as we've sort of already talked about. One of the important reasons for looking at a blood film in a low platelet count is to ensure that this is really a low platelet count and not something called clumping. Have you heard of clumping before? Platelet clumping.
Is that when they sort of, you look at the film and they're clumped together, but the flow can't sort of differentiate them, so thinks that it's a low number, but actually when you look at it, if you counted them with a human eye, you would go, no, this looks fine.
Exactly. So the lab machines are counting clumps of platelets as one platelet, when actually there are many more. And it's an artifact, usually due to an EDTA-induced antibody, which basically clumps the platelets together. And you can see them clumped on a blood film, particularly when you look at the tail bit of the blood film. And so if you do want to know a patient's true platelet count in that situation, you ask the medical or surgical team to send the patient's blood again, but this time in a citrate, so a blue top sample, so that they don't have the EDTA-induced antibody. And instead, you can do a full blood count off that citrated sample, and that will give you a real platelet count. So always rule out clumping, otherwise, you're wasting your time doing further investigations if it's just clumping. It's just a lab artifact. But the film is really important for, as we said, red cell fragments and making sure that it doesn't have any of them. But also you can get clues from things like the white cells. They can often look quite reactive in infection and in ITP. So in ITP, you can get this scalloping of the lymphocytes where they kind of engulf the red cells, and that can be seen in ITP as well as also viral infections. And in somebody who's really sick with sepsis, you may see toxic granulation of the neutrophils, for example, which will give you a bit of a clue. So blood film is really useful. Then you're going to do your LFTs and your UNEs. You're going to do your hematinics and your coagulation profile to look for things like DIC. And you're also going to do your viral serology, so hepatitis B, C, and HIV, in case you need to immunosuppress the patient, and also because they can cause a low platelet count. You're going to do your immunoglobulins to look for low levels of antibody in things like common variable immunodeficiency, which is particularly important in children. And if you have a woman in fertile range, then you may also want to do a pregnancy test. So those would probably be my first investigations. And then you need to think about, if you think it might be a secondary ITP, then you might want to do an autoimmune screen. So an ANA, double-stranded DNA, and some of your other autoantibodies, your ENAs. You might want to do your thyroid function test, because 10% of ITP patients also have hypothyroidism. You might want to do antiphospholipid antibodies if you think the platelets are low due to antiphospholipid syndrome. You may want to do an ultrasound scan of the abdomen if you think you can feel splenomegaly or hepatomegaly. And you're going to do potentially an H. pylori antigen test, because that can be associated with ITP, and you'll want to do triple eradication therapy for that. If you think there's any signs of hemolysis, do your retic count, do your DAT to look for that. And you may want to do viral PCR for EBV, CMV, and parvovirus. Now, obviously, you're not going to do all of those other investigations in everybody that you think has ITP, but that's why your history and examination are really important, to allow you to then decide what of those investigations you might also choose to do.
That makes sense. So if you think it's ITP, you have to search for the why. And then when you find your why, you're allowed to diagnose. Yeah,
exactly. You just have to rule out all the other causes first, because it's a diagnosis of exclusion.
Yeah. This is haematology. So when do I get to do a bone marrow?
Okay, I mean, that's a good question. And unfortunately, there are no sort of hard and fast rules for that. But essentially, I would be thinking about doing a bone marrow biopsy in somebody who doesn't respond to treatment in the way that you would expect, or if they had atypical features. Like I had somebody the other day who was a bit older, he was over 60, and he presented with a low platelet count and a petechial rash. And he also had a neutropenia, which had been going on for a while. And so I was worried about possible myelodysplasia. So I did a bone marrow for him. And the other thing is that a lot of the guidelines will also recommend that you do a bone marrow biopsy before starting the more novel treatments that we'll talk about in ITP, such as the TPO receptor agonists. In reality, I'm not sure how much we really do that, and we're probably not very good at doing that. But the reason is that some of them can increase your risk of developing bone marrow fibrosis, and therefore having a baseline bone marrow aspirate and trophine can be quite useful to compare. But most patients with ITP, you don't need to go as far as doing a bone marrow biopsy unless you have some other concerns, essentially. Okay, so let's take a case then. I've got a patient with a platelet count of 40, and I've gone through everything we've just said. I've done my investigations, I've done my history and examination, and I feel pretty confident that I've ruled out other causes of a thrombocytopenia, and therefore I think that this is immune thrombocytopenia. How would you go about treating this patient, David?
So this is clearly a trap, and I'm clearly going to fall into it because I'm the kind of person who wants to do stuff. So depending on the cause, I'd want to treat the underlying cause, whether that's an autoimmune thing. And if there's any bleeding symptoms, I'd want to give them platelets, which will probably turn out to be completely erroneous. But
Okay,
I'll learn my lesson.
fine. So it was a bit of a trap. So you clearly know me well enough by now. Essentially, this patient's platelet count is 40. What you really want to know is, does the patient have any significant bleeding, clinically relevant bleeding? If it's just very minor bleeding or no bleeding at all, which is the most likely thing in ITP with a platelet count of 40, then actually this patient probably doesn't need any treatment. And so our management would just be watch and wait. And how frequent that would be in terms of monitoring full blood count would depend on whether the patient has any bleeding symptoms at all, how worried the patient is sometimes, and their age, and whether they have any other risk factors for bleeding. And it would just be about monitoring a full blood count, maybe weekly to start off with, and then going to monthly, something like that, and then going to 3 monthly, 6 monthly, and they may never need treatment. So I think that's a really important, the reason I brought up this case was purposely to illustrate that not all ITP needs treatment, and a lot of chronic ITP with a platelet count of something like 40 and no issues from it doesn't really need any treatment, just reassurance and watch and wait. Okay, so what about if we took a patient with a platelet count of 12 this time? And again, I'm happy that the diagnosis is probably ITP. How would you treat this patient, David? And I guess the first question for you is, would you admit this patient?
Help, I think I feel like I'm in that trap again. So I guess if the patient's symptomatic, that would probably be the tipping point. If they're actively bleeding, I would need to do something about it. So admit if it's low and they were bleeding is probably where my head's at.
Yeah, I think that's reasonable. The BSH guidelines recommend if the platelet count is less than 20 and it's a new diagnosis of ITP, then you need to admit the patient.
Okay.
Note that if, therefore, a patient is known to have ITP, they come to the haematology clinic with ITP, and they frequently have a platelet count of less than 20 with mild mucocutaneous bleeding, then actually you probably could manage them safely as an outpatient. But in the context of it being a new patient, you're not quite sure how it's going to affect that patient, and the platelets are less than 20, then you probably should admit that patient to work them up a bit more and to monitor them for bleeding and to initiate treatment. So I guess treatment can then be divided into the emergency situation you were talking about. So if they have emergency, severe or life-threatening bleeding versus non-emergency management. So if we start with emergency management, you said you would give platelets. Do you think platelets would be useful in somebody who's having life-threatening bleeding with ITP?
So I don't think they'd last long, but yeah. I would probably think that I would give just to see if I can plug any gaps just in the meantime.
Yeah, absolutely. That's perfectly reasonable. So that's one of the things that you're going to do in a severe bleeding ITP patient is you are going to give platelets, but with the acknowledgement that they're not going to last very long. And I think that's key to explain to other people looking after that patient. I've often had patients with ITP with, let's say, a bleed in their brain, so quite worrying. And the clinicians there, the general medics and the nurses, are very focused on getting the platelets in. And once they get the platelets in, they kind of relax, and they don't understand necessarily that actually they're not going to last very long. And actually the other therapy is really important, if not more important, arguably, in allowing a maintained platelet count to actually go up and stay up and be useful. So the other treatment that we would initiate is IVIG. So intravenous immunoglobulin. And so we would give that at 1 gram per kilogram. And it's really helpful if you have a specialist nurse in clotting who can go down to A&E or go to the ward or wherever the patient is and help facilitate the actual administration of that, because it can be quite tricky for the nurses. And then it can be repeated the following day if the platelet count remains less than 50, but it has quite a fast onset of action. And then the third thing is you're going to give steroids, and usually that would be dexamethasone, 40 milligrams IV, or 1 gram of IV methylprednisolone for 3 days. So basically what you're doing is trying to switch off the destruction of the platelets as quickly as possible, because that's going to allow your bone marrow that's furiously kicking out new platelets to allow your platelet count to come up and to stop life-threatening bleeding. Obviously, you're going to do your whole A to E assessment. You're going to do your major hemorrhage protocol if the patient's having that sort of bleeding. But the key thing is, as you correctly identified, that those platelets aren't going to be as useful as they might be in another patient. And then just basic things not to forget. Don't forget to review the drug chart for antiplatelets that the patient might be on, or anticoagulation. You know, they might be on some of these medications because this is an acute problem that suddenly happened, and it was perfectly reasonable for them to be anticoagulated or on clopidogrel beforehand. And bearing that in mind is really important, and thinking if there's anything that you can reverse there.
I guess there's those awkward conversations from the post-take ward round when you're like, yes, I did know about that hideous oversight of the clopidogrel and the aspirin that they're on. I'm very sorry.
Yeah, exactly. And even things like ibuprofen and other non-steroidals, which will impair your platelet function. Those are things that can sneak their way onto the drug chart or remain on the drug chart of somebody that actually really, if you thought about it, probably do need to stop. So that's your emergency management. And then your non-emergency management of this patient. So let's say they're not having life-threatening bleeding. We would call this rescue therapy instead. And rescue therapy is basically patients who have a low enough platelet count that we actually do want to treat them, even in the absence of any significant bleeding. The BSH classify that as a platelet count of less than 20 that you would want to start treatment for ITP. And ASH say, or the American Society say, less than 30. But it's around that level. And that's the level at which actually treating the ITP is justified, because you're trying to keep that patient out of trouble in terms of bleeding. But also it's reasonable to start rescue therapy in patients who don't have life-threatening or severe bleeding with a platelet count of over 20 if they have some other additional risk factor. For example, you may have a patient who's an avid skier and is about to go skiing in the Alps. And so you don't really want them to be skiing with a platelet count of 25. Or if they have an upcoming operation and you want to get their platelet count up for that, then that would also be a reasonable decision to treat their ITP. So in this situation, first line treatment of non-emergency management would be steroids again. But you've got a choice of steroids. You can either go for prednisolone 1 milligram per kilogram with a maximum dose of 80 milligrams, oral daily for maximum of 2 weeks duration at that dose. But be aware that in an elderly, frail patient, you may well want to consider a lower dose of prednisolone, so half of that dose, so maybe 40 milligrams, for example, or 50 milligrams of prednisolone a day. And then the other option, if you don't want to use prednisolone, the other thing you can use is dexamethasone. And for dexamethasone, you give 40 milligrams once a day, daily for 4 days. And so it's just a more short, sharp burst of dex, or you can go for the 2 weeks of prednisolone. And both of the steroids, your response rate is about 50%. Okay, so 50% of your patients are going to respond to those steroids and 50% are not. So it's not a super effective treatment, which is surprising in a way. I would say that, so if you go down the prednisolone route and the patient is responding and their platelet count starts coming up after a week, so I would check their full blood count within a week of starting the prednisolone, usually a couple of days and then a week. If they're responding, then I would then taper down over 3 to 4 weeks to nothing. But if they're not responding, so if their platelet count is less than 50 after 2 weeks of that maximal prednisolone dose, then rapidly taper that prednisolone off over a week, because there's no point having a patient on prednisolone with no response to platelets. If you're going to respond, it will be within that first 2 weeks of maximum dose. And if they haven't responded at that point and their platelets are still less than 50 at 14 days, then just get them off the steroids as quickly as possible over a week, because you don't want to expose them to the side effects of steroids when it's not working. So clinical review at 5 to 7 days, make sure that that starts to look like they're responding, check their hemoglobin is stable. And then at 14 days, if they're not responding, taper off over a week. If they are responding, taper more slowly over 3 to 4 weeks to nothing. If you go down the dexamethasone route, in a way, it's more simple. You just give 4 days of oral dex, 40 milligrams, and then you review them at 7 days and see what their platelet count is. And so the advantage of using dexamethasone over prednisolone is particularly in those where you don't want them to be on steroids for very long. Let's say they have type 2 diabetes and it's going to cause haywire BMs. Or if you have a patient who's nil by mouth, you can give the dexamethasone IV. But the advantage of prednisolone is it feels a bit more like you can taper it up and down a bit more. So you can go for a lower dose that feels a bit more appropriate for possibly a more frail or elderly patient that's out in front of you. The dexamethasone is slightly quicker in terms of the response, so by a couple of days, but overall both are the same amount of response rate, so they're equal in efficacy, just the dex is a little bit quicker. And if at 7 days you find the patient who's had the dexamethasone platelets haven't come up, then you can repeat that pulse of dex for 4 days again and see if that has any benefit. But if it doesn't have any benefit after the second pulse, then it's unlikely to. And then you might ask me, well, what about the patients that absolutely cannot have steroids? Let's say they have a background of schizophrenia or some sort of mental health condition, which means that steroids are just really contraindicated. Or you have a patient that has an operation that cannot be delayed in a couple of days and really needs to go ahead for that, then actually your steroids are probably not going to be the right thing. And instead you can use IVIG in this situation. So the same as for the emergency or life-threatening bleeding. And that's in the same dose again, so 1 gram per kilogram. So that's an option if there's an absolute contraindication to steroids or you really need a rapid rise in the platelet count. And then you also need to think about supportive care. So can you think of anything else you might want to add in terms of looking after a patient with ITP that you've started treatment on?
So I guess if they're on a large amount of steroids, they have to be aware of what they need to do with steroids, the old steroid card thing.
Absolutely.
And I guess we mentioned about drugs and what medication they're on, and I imagine optimizing the other parts of their clotting cascade. So if we can help the clotting cascade along, that's probably going to help out overall.
Yeah, sure. I mean, most ITP patients you would expect to have a completely normal clotting profile. So if they don't, you would be worried that you might have got the diagnosis wrong. But certainly counselling about steroid side effects, providing them with a card is really important. Thinking about bone protection and gastric protection, so a bisphosphonate and calcium, so calcium and vitamin D. Thinking about bone protection and whether they need to be assessed with a FRAX score, in which your high-risk patients will have the bisphosphonate, your medium-risk patients will be referred for a DEXA scan. And if you're under the age of 40, you don't need to be quite as worried about bone protection, unless you think they're going to have really high doses or repeated doses for some reason. If they're diabetic, remember, counsel them about their blood sugars and ensure that they're able to monitor their blood sugars at home. And also make sure you contact your haematology specialist nurse, of which most hospitals will have a specialist nurse in coagulation, and they can provide written information and 24-hour contact details for haematology for these patients as well. And the other thing is tranexamic acid, so 1 gram 3 times a day orally or as a mouthwash can be really useful if there's mucosal bleeding. But what must you make sure that you rule out before giving somebody tranexamic acid?
I've no idea.
So you need to make sure that they haven't got any hematuria, because otherwise you can precipitate clot retention with tranexamic acid. Okay, great. So that would be your initial treatment, David, of your non-life-threatening ITP patient with platelets of less than 20. Does that make sense to you?
Yes, yeah. I guess the emergency ones are the ones that sort of will stick with me, and then I can sort of re-look up the algorithm to make sure I'm going through the sort of when I've got a bit more time. So yeah, no, that's good.
Yeah. Essentially, it's steroids for both emergency and non-emergency situations. But with your non-emergency, you've just got a choice of whether you go for 4 days of Dex or whether you go for 2 weeks of prednisolone.
Yeah.
And that's just about picking which one works for that particular patient, really, in terms of side effects and how long they're on the steroids for. In terms of the response timescales, IVIG will probably take 1 to 3 days to respond. So that can be quite stressful when you've got a patient, as I've had before, where they've had a subdural hemorrhage and they've got platelets of 3, and you're giving them platelet transfusion, but it's not really made any difference. And you've given IVIG for 2 days and their platelet count hasn't come up yet. So expected time to response is 1 to 3 days. That can be quite nerve-wracking. IVIG, generally the peak response is 2 to 7 days after infusion. For prednisolone, the expected time to response is about 4 to 14 days, so it's quite a lot slower, which is why we use IVIG in emergencies. And the time for the peak is a week to 28 days, that kind of timescale for prednisolone.
Okay, and what does a response look like to you?
Yeah, so technically a response to treatment is either a platelet count of above or equal to 100 or above or equal to 30, as well as as long as it's double the baseline platelet count that the patient started with. And then either being above or equal to 100 or above and equal to 30 and doubling of the baseline needs to be on 2 different occasions, at least 7 days apart. So if they have achieved that, then that would be that they have responded to treatment. And we would say somebody is, I guess it's probably not accurate to say that somebody's in remission from ITP, but certainly somebody who I'd be very happy with is someone with ITP with a platelet count of greater than or equal to 30, not on treatment. So okay. I guess that would be the goal, as well as.
Okay, and if we don't manage to reach those thresholds with our sort of first line treatment, where do we go next?
Yeah, so then you have to move on to second line treatment. So let's say we've had our patient with platelet count of 12, and we started them on, let's say, prednisolone for 2 weeks, maximum dose, so 1 milligram per kilogram. No response. We tapered it off rapidly over a week, and now we're stuck. We've got this patient, they've got mucocutaneous bleeding. It's not severe, so they're not admitted or anything, but they've got a platelet count of 12 still. Where do we go? And so second line treatments, you've got firstly other forms of immunosuppression, which are what we call steroid sparing, because what you don't want is to end up having this patient on steroid that they're not responding to, or steroid that they do respond to, but you can't wean them off it successfully and they relapse. We don't want an overdependence or prolonged course of steroids in any of these patients, because steroids fundamentally are great drugs, but they're also really bad drugs. And we don't want anyone on long-term steroids. So then you look at your steroid-sparing agents, which are things like mycophenolate and azathioprine. So mycophenolate, you typically start at 500 milligrams BD, increasing to 1 gram BD if tolerated, or azathioprine, where you can do 1 to 2 milligrams per kilogram daily, and you can increase that to a maximum of 150 milligrams daily if tolerated. So that's one option. The other option is you could try rituximab. So this is usually 100 milligrams IV weekly for 4 weeks. And the response rate to rituximab is probably about 40%. And it's quite slow. It takes at least a week for an initial response to occur. And it can take, for the peak, it can take from anything from 14 to 180 days. So quite a slow response, but is sometimes favored in some patients even now who don't want to be taking a tablet or an ongoing treatment. So, they just want to do the 4 infusions and then not have to be bothered by doctors too much.
I can't blame them.
Both of these treatments, though, they're both very immunosuppressive, and this really became more of an issue with COVID. And it's an example of an area in haematology which has really been accelerated, I think, in terms of progressing forwards with treatments, thanks to COVID. Because in the COVID era, we weren't keen to immunosuppress people for these low platelet counts. So are there any other treatments that you know of in ITP which don't lead to a significant suppression of your immune system, David?
Yeah, so I was going to say, if you can't dub down the sort of the bit that's destroying the platelets, can we make more of them? So anything that's sort of the big red button for your liver to pump out some TPO would probably be the other way forwards. And I've heard of Romiplastin and other ones that I struggle to pronounce.
Perfect. Yeah, exactly. So what you're referring to is TPO receptor agonist. So TPO, thrombopoietin, it's like EPO, but it's of your platelets instead of your red cells. Everyone's heard of EPO, drug doping, boost your red blood cell production. But TPO is the same. It's a hormone that's used to boost your platelet production. So it's made by the liver. And that's one of the reasons why patients with chronic liver disease have low platelets, is because they don't make enough TPO to stimulate their platelets to be made. And then TPO goes to the bone marrow, where it stimulates your megakaryocytes to make more platelets. And we've got various different types of TPO receptor agonists, but they essentially are all drugs that bind to the TPO receptor, probably on the megakaryocytes, and boost, therefore, the bone marrow production of platelets. To do exactly as you say, if you can't stop the production, you can't stop the destruction, maybe you can increase the production of platelets instead. And so you mentioned Romiplastin. We've also got L-Trombopag, and we've also got Avatrombopag. So technically, L-Trombopag can't be used until you've had at least 6 months of ITP by NICE approval. And technically, Romiplastin and Avatrombopag can't be used until 12 months, i.e. chronic ITP. And all of these TPO receptor agonists cannot be used until you've failed steroids or your standard rescue therapy. So they are second-line treatment is how they are currently funded. But in reality, if you've got a patient who's got a platelet count of less than 20 and they've not responded to steroids, you're not going to wait until 6 months to reach for the TPO receptor agonist. And we're reaching for them more and more these days. One of the reasons for that is that they're very well tolerated, generally, as a class of drug. The other thing that's amazing about them is that the response rates that we're looking at are about 70% or more, which is amazing. The response is usually after a couple of days, but peaks at about 14 days. And sometimes it can be hard to know quite how effective it's going to be in a patient, and you can overshoot and actually give them a really high platelet count, which can feel quite stressful because we know that their platelets in ITP are bigger and stickier than usual. And so we then just have to pause treatment and allow it to come back down, or dose adjust the treatment. But remember, just an important side fact for you is that you do have higher rates of VTE in ITP compared to normal patients without ITP. But
slightly ironic, isn't it?
Yeah, I know, exactly. But the platelet count number doesn't actually correspond to your increased rate of clotting, which I think is quite interesting. So let's go through the 3 TPO receptor agonists in more detail then. So we start off with L-Trombopag. So this is NICE approved for patients with ITP of greater than 6 months duration, as we said, but we in reality use it earlier than that if we need to. And they must have failed at least first-line steroids or standard rescue therapy. It's a tablet that's taken once a day, which sounds great, and you start at a dose of 50 milligrams orally once a day, or if you're of East Asian ancestry, then you actually start at a reduced dose of 25 milligrams once a day. I bring that up because I have seen that come up as an MCQ on multiple practice banks for part 1, FRC Path.
Okay, golden nugget accepted, thank you.
Yeah. And you then titrate it as per response up to a maximum of 75 milligrams once a day. But although it is a tablet and that sounds all absolutely fine, this tablet's really annoying because it needs to be taken 2 hours before or 4 hours after any products that contain calcium or iron, magnesium, aluminium, selenium, and zinc. So any polyvalent cations, which means in reality, you can't wake up and take your tablet and then have a cup of tea with milk in it if you have milk in your tea. So actually that can be really difficult. And it means it can actually be quite tricky for patients to time taking that tablet in reality so that they're actually absorbing it. Something that I have seen one of our specialist nurses do, which I thought was brilliant, was older men who get up in the night to pass urine because of their enlarged prostates. She suggests you take the tablet then in the middle of the night, which I thought was quite a novel and interesting idea, but makes sense because that's a really reliable time of which you're not going to have any interaction to prevent absorption of that drug. But you see what I mean. It takes some planning around your lifestyle to.
I have to say, I would be very unhappy if my morning routine of a coffee was interrupted by a tablet.
Yeah, exactly. It also requires regular liver function test monitoring. Hepatotoxicity is reported in up to 15% of patients, and it does carry a black box warning for a risk of hepatotoxicity. So you continue it for 4 weeks at the maximum dose, and if you haven't had any response at that point, then you should stop it. The study or the trial that led to L-Trombopag being used was the RAISE study. I remember it as like raising the platelet count. And that was published in the Lancet in 2011. So this drug's been around for quite a long time now. And it was a randomized control trial of placebo versus L-Trombopag. And the response rate was 79%. So this is an extremely effective drug.
Yeah, especially when you're looking at steroids at 50 and things like that. That's pretty good going.
Exactly. And comparatively, compared to high-dose steroids, the side effects are vastly reduced. And interestingly, even though it has this risk of hepatotoxicity, it's been licensed for also being used in patients with hepatitis C virus infection, where the main thing that's limiting their ability to have treatment for their hep C is their thrombocytopenia. You can use L-Trombopag in that situation to boost the platelets to allow them to have their interferon-based therapy for that. So I always find that kind of a bit of a kind of confusing fact, which again has come up in an MCQ, because you think, well, surely you wouldn't use that if it's got a black box for toxicity to the liver. But anyway, so that's L-Trombopag. It can also be used in aplastic anemia as another interesting aside for patients not suitable for other treatments. But anyway, we won't go into that for now. So that's L-Trombopag. The second one is the one that you mentioned, which is romiplostin. So this is technically approved for those who have had ITP for more than 12 months. It's an injection instead of an oral tablet, and it's subcut once a week, which means that you can eat whatever you like, but a lot of patients are not going to want to inject themselves or have someone inject them. You supposedly start at a dose of 1 microgram per kilogram or 100 micrograms subcut weekly. And that was because the trial started at 1 microgram per kilogram and then increased by 1 microgram per kilogram per week until you got a response. And that allows you to kind of slowly titrate up the dose to find the minimal dose that's required for that patient to maintain a reasonable platelet count. But in reality, the vials come as the smallest vial is 250 micrograms. And it seems quite wasteful to sort of squirt out some of that and then give the rest. So in reality, we usually start at 3 micrograms per kilogram, which is roughly 250 micrograms weekly. And that's generally what we start at. The treatment is really well tolerated, other than having to take subcut injections once a week. But there is this side effect of it increasing bone marrow reticulin, which is why we were talking about earlier. You would consider doing a bone marrow before starting romiplostin in case you run into trouble later on where you suspect the patient's developed fibrosis in the marrow. So that's romiplostin. And then you've also got avatrombopag, and this is also NICE approved for ITP more recently in December 2022. And this is a tablet. and it's a tablet taken once a day, and you think, oh no, it's going to be the same as L-Trombopag, but it's actually not. It doesn't have the same problems of absorption. So it's a bit of a game changer. So you start at 20 milligrams once a day. You can increase to a maximum of 40 milligrams once a day. And again, discontinue after 4 weeks if there's no response. And yeah, this seems to be very effective as well, and also tolerated really well. And actually, I think there's probably a move now with most clinicians to move to avatrombopag as first-line TPO receptor agonist after initial rescue therapy with steroids, because of the fact that it's a tablet, but you can take it and still have a cup of tea in the morning. The other use of avatrombopag, just as an aside, is that it was initially licensed to be used in chronic liver disease patients. In fact, it reminds me of something I was called about the other day on call, a patient who has chronic liver disease waiting a liver transplant and needs a lot of teeth being pulled out by MaxVax. And MaxVax phoned me to ask what we should do about that. And I suggested that we use avatrombopag because you can start it a couple of days before the procedure and then monitor the platelet count and then do the procedure. And that's quite beneficial compared to transfusing platelets, where you're exposing that patient to, 4 donors for every pool of platelets, and the associated HLA exposure and antibodies that the patient might develop, which would be really relevant in someone waiting a liver transplant. So that's avatrombopag. So those are your 3. So avatrombopag, L-Trombopag, and romiplostin.
Nice. So I've embarrassed myself by giving someone a mispronouncing avatrombopag for however long, say 2 to 4 weeks, and there's been no response. Where am I going next?
So then at that point, well, that's a really interesting question. I find this incredibly interesting because you would think, okay, well, TPO receptor agonists haven't worked, so we now need to move to something else. But actually, what trials have shown is that if you switch from, let's say, avatrombopag to romiplostin, even though they're technically the same drug mechanism, your response rate is about 50% in patients that have failed the first one. So I find that really interesting because it's the same.
That sounds ridiculous. That sounds like a marketing ploy, doesn't it?
No.
Do more of the same. It'll be fine.
Yeah, exactly. That is literally it. So that's what I would do next, is I would switch to a different one. Then other options are, you've got things like fostamatinib. I don't know if you've heard of this.
Not at all.
I don't know how you pronounce it, SYK or psych, but it's a SYK inhibitor, which stands for spleen tyrosine kinase. And essentially, it's been licensed for patients who have failed TPO receptor agonists. And it essentially works by reducing antibody-mediated platelet destruction by inhibiting the FCR-triggered psych-dependent cytoskeletal rearrangement during phagocytosis of platelets, which sounds very complicated, but essentially it's stopping phagocytosis of platelets in the spleen.
So it's stopping the little arms on the macrophages pulling in platelets.
Yeah, exactly. The platelets that are covered in antibody. So because it's blocking that. So It was approved in 2022 for patients with ITP. And that was based on the trial FIT1 and FIT2, which was a double-blind randomized controlled trial, phase 3, of placebo versus fostamatinib. And it had a response rate of 1 in 5 patients. So not amazing. And also they found that the response reduced over time. But in my experience and from having spoken to people that have used this drug quite a lot, it's still worth trying for these patients with very refractory ITP, because for that one patient out of every 5 that you do find a response, that might just be your savior for that patient. So I think it's still worth trying, just in case your patient is that 1 in 5. And then other options, clinical trials is where you should be looking at this point. Sometimes combination therapy, which is a bit off license, but maybe trying 2 different TPO receptor agonists, for example. You can try danazol or cyclosporin, and other immunosuppressive type agents is what you're going to have to go back to. So things like cyclophosphamide even, or alemtuzumab. And ITP is one of those things that can either be something that responds really easily to steroids at the beginning, goes away, never comes back. Or sometimes in some cases, it can be really just such a pain to get on top of. And so that's this population of patients here.
So if the spleen's the problem, why can't we just whack the spleen out? Why can't we have a splenectomy?
Oh, yes, that's a good point. Yeah, I forgot to say about splenectomy. So the splenectomy was something we were doing a lot more of in the past. They advise, obviously, a splenectomy is very irreversible. Once the spleen's gone, it's gone. So you should definitely delay that until after at least a year of diagnosis of ITP, because in some cases, people have a spontaneous remission of their ITP in the first year. There's actually pretty good response rates of splenectomy, so an 80% response rate, but you need to make sure that you are happy with the diagnosis beforehand. And also they advise, and I don't know how much this is done in reality, because I honestly haven't seen somebody who's had a splenectomy in this era of TPO receptor agonists now, but certainly they used to do a 111 labeled platelets. I'm not making any sense, sorry. Radioactive labeled platelets to study the patient's platelets to see that they are actually sequestered in the spleen prior to removing the spleen. Because if you have a mixed picture of hepatic and splenic sequestration, or just hepatic sequestration of platelets, because remember, your reticuloendothelial system exists both in your liver and your spleen, then it wouldn't be recommended to remove the spleen.
I guess that people will be quite put out if you remove their spleen and they continue to have problems.
Well, exactly. And you also need to get a platelet count above 20, or at least equal to 20 pre-op. It's quite bloody surgery.
I imagine.
So that can be a chicken and egg situation. You need to think about the fact that they're going to need prophylactic penicillin V for the rest of their life. They'll need to have all their vaccines to things like strep pneumoniae, Haemophilus influenza B, Neisseria meningitidis, at least 2 weeks prior to having their spleen out. And you also need to be aware that they may well have an increased risk of clots after their spleen's removed, because if you're boosting their platelets, and around the time of the spleen surgery, you may find that you develop thrombosis. So yeah, it's not as easy as just whipping out the spleen. And I think it probably is still done, but I haven't seen it.
Feels very last ditch.
Yeah.
Okay, you've convinced me that splenectomies are a thing of the past. What's the future?
Yeah, well, it's a good question. I think probably the more we learn about ITP, the more we realise that probably this is lots of different mechanisms underlying slightly different types of immune thrombocytopenia that are being lumped together as one. And that probably explains why some patients will respond beautifully to steroids one course and will never be troubled by their ITP again, whilst others end up going down the sort of clinical trial route, having not really responded to anything. So I think in the future, it's going to be about understanding how ITP is really mediated, but also how do we establish which mechanism is underlying the disease process in different patients so that we can target our treatments better in the future. I think that's probably the direction of travel.
Grand. And is there anything else I need to consider in a patient with ITP?
Yeah, that's an important question as well, David. I think don't forget the non-bleeding symptoms in ITP is what I would say. So there's high anxiety levels in many of our ITP patients, even when their platelet count has responded and is above 20, the sort of watch and wait or watch and worry. So think about things like the ITP Support Association, which is a very helpful website for patients. And make sure you explain to patients that, I think it goes a long way to explain to patients that you may have a really low platelet count of 25, for example, and they look at the reference range of 250 and they think,
yeah,
but actually explaining to them and taking the time to say, look, your platelets are bigger and stickier and more effective than other people's platelets can go a long way in alleviating their anxiety. So I think that's really important. I think also don't underestimate the constitutional symptoms that many ITP patients complain of, particularly feeling very fatigued. That's the second most common symptom in ITP after bleeding. And don't forget this paradoxical VTE risk, of which we touched on it before when we were saying about how the platelet count doesn't correspond with the VTE risk, but patients with ITP are at higher risk of blood clots, particularly if they've had a splenectomy. And so that's just also something else to bear in mind.
Yeah, I think that one will stick with me just for sheer, I don't know, paradoxicalness in my brain.
Yeah, exactly. And I think no discussion about ITP when thinking about preparing for FRC Path Part 1 would be complete without thinking about low platelets in pregnancy, because it's a hot topic that they love to bring up in essays. I think because it really challenges your kind of understanding as to how to treat ITP. So just to talk about low platelets in pregnancy briefly, David, what is the most common cause of a thrombocytopenia in somebody who's pregnant? Do you know?
So like a gestational thrombocytopenia.
Yeah, good.
Yeah.
Yeah, so gestational thrombocytopenia is basically a normal phenomenon. So many pregnant women, about 10% of pregnant women, will have a drop in their platelet count during the second half of their pregnancy. And it's due to probably a combination of increased activation and sequestration of platelets within the placenta, as well as also the fact that they undergo big hemodilution. All your reference ranges are different in pregnancy because you expand your plasma volume by 50% and your cell volume by about 25%. So there's going to be a dilution effect of your platelets. But usually gestational thrombocytopenia, you're looking at a level of between 100 to 150. I think if your platelet count is less than 100, then something in your back of your mind should be saying, this is pretty unusual. It's only 1% of pregnant women will have a gestational thrombocytopenia of less than 100. And if it's less than 80, then I would encourage that to be an alarm bell in your head as to think of other causes, okay? And I guess what are the other causes in particular that we need to think about in pregnancy, David?
So I guess these are our MAHAs again. Are we worried about sort of DIC and ITP and bits like that? Sorry, the immune bits, TTP.
Yeah, TTP.
That's where my brain was going.
Yeah, so absolutely MAHAs, because they are more common in pregnancy and very serious. So you have your TTP, and that's particularly relevant in pregnancy because actually it's the biggest trigger for TTP. I think it's something like 25% of TTP is triggered by pregnancy. But also things like your preeclampsia, which can progress to your HELP syndrome, which also present as a MAHA, as well as getting low platelets from acute fatty liver of pregnancy, and also then thinking about all of your other non-pregnancy specific things. But in particular, you want to rule out your MAHAs. So a patient who's pregnant, particularly in the second half of their pregnancy, and their platelets are less than 80, you must look at a blood film. That's absolutely key.
And so is ITP quite common in pregnancy?
Yeah, it is actually. So it's the second most common cause for a low platelet count in pregnancy. So after gestational thrombocytopenia, your next thing you're going to be thinking about is ITP once you've ruled out your serious MAHAs with a blood film and other investigations first. And I think the key message of maternal ITP is delay treatment as much as possible. Try not to treat these patients, okay? The main treatment is going to be watch and wait. So cut-offs to have in your head. Aim for a platelet count of above 30 for pregnancy just generally. Okay, so we had 20 before for non-pregnant patients. It's probably more like 30 for a pregnant lady. Aim for a platelet count of above 50 for labour. Okay, so that doesn't actually sound that high, but actually, you know, major surgery you can perform with a platelet count of 50 and above. So that's your cutoff. Remember, these are particularly sticky platelets as well. And then also think about spinal and epidurals, okay, and this very critical site of bleeding. So there you want a platelet count of above 80. So it's 30 to maintain pregnancy, 50 for delivery, and 80 for a spinal or epidural. So those are the things that you need to think about. And so then you may ask, okay, well, if the main management for maternal ITP is just watch and wait, what are we talking about here? So what I mean by that is, if you think it's gestational thrombocytopenia, then you need to just check the platelet count again at your routine midwife appointments. They have bloods at 12 weeks and 28 weeks, and then do a full blood count 1 to 3 months after delivery to make sure the platelet count has come back up after delivery, because if it's a gestational thrombocytopenia, it should have resolved by then. But if you think it's ITP, then you should really be doing a full blood count every 2 to 4 weeks. And if it's less than 80, and you're very happy that you've ruled out all the other causes, then after week 34, you should be doing weekly full blood counts. Okay.
Yeah, that makes sense. And so we've got those guideline figures, and are those the numbers? If you went over those thresholds, is that when you're treating?
Yeah, so indications to treat would be if you're in your third trimester, late into your third trimester, and your platelets are less than 80. So, for example, if you're 1 to 2 weeks prior to the anticipated date of delivery, that's when you'd be wanting to start treatment. So really, it does feel quite like scarily last minute, I feel. But that's what you're supposed to do. Or if your platelets were less than 30 at any stage in your pregnancy, you would be wanting to do something about that. So first or second trimester, platelets less than 30, you're going to want to intervene. But also platelets are less than 80, coming up to delivery is when you're going to want to act. And your treatment options are basically going to be either steroids, of which we start at a much lower dose, so 20 milligrams of prednisolone once a day, and then titrated up slowly. So not the 4 days of Dex, but 20 milligrams of pred. And that's because we don't want to expose the mother or the fetus to these steroids. So we start low and slow. And usually they'll work within about 2 weeks. So you need to be quite patient. And take that into account when you think about when you're going to start and how high you want to get the platelets to. The other option is if you're getting really close to the delivery date, or the woman starts going into labor, which is not planned, then you can give IVIG. So a bit like with the emergency bleeding situation. So 1 gram per kilogram in 1 or 2 divided doses. And that should get your response. Remember that IVIG can respond within a day. So 1 to 3 days, you start getting a response. So hopefully that will get your platelets up enough. And often if you have got somebody who's suddenly going into labor and your platelets are less than 50 or less than 80, depending on what type of analgesia she's going to want, then you're likely to give higher doses of steroid and IVIG together and throw both of them at the patient to try and get the platelets up as quick as possible. We don't use rituximab, and the reason we don't use rituximab is because that will cause immunosuppression of the neonate, so we really don't like doing that. And platelet transfusion, again, is reserved for bleeding. You wouldn't want to give platelets to facilitate a spinal or an epidural because those increments are so short-lived that you wouldn't feel confident in providing hemostasis doing that. And all the cases that I've seen have been managed really well because of it being planned in advance. So the diagnosis is made earlier on in pregnancy, and then it's discussed in a multidisciplinary team meeting. And ideally, these patients should be seen in a joint haematology and obstetrics and anaesthetics clinic, because there's quite a lot of things to consider. So, you have your booking bloods and you've got your bloods at 28 weeks. And at that point, if you've got a low platelet count, that's when you start making a multidisciplinary team meeting or clinic, and then a plan that's clearly circulated to everybody involved, including blood bank, so that everyone is aware of this higher risk patient going into labor. It
sounds scary. And I guess it's quite scary being, the responsible hematologist on that side.
Yeah.
How do you make sure you've covered your bases? Do you have like a process that you use to think through? Have I thought of everything here?
Yeah, I think if you always think about it in terms of risk to the mother and then risk to the baby, then actually you won't become unstuck. So in terms of risk to the mother, you need to think about, firstly, the anaesthetic or mode of delivery. So if she wants a C-section, for example, or if she needs a C-section, then you're thinking about a spinal. So there you're thinking about platelets of 70, 80 sort of cut off. And that's important to consider from the beginning, and the potential for needing that if labour doesn't progress in the normal way. You also want to think about tranexamic acid, which should be given from the onset of labour. And also then thinking about VTE prophylaxis post-delivery. So thinking about if their platelets are above 50, making sure that they have low molecular weight heparin afterwards, because we know their platelets are very sticky. And then the other thing to think about is other sort of hemostatic measures like active management of the third stage of labour. So you think about it in terms of that. So risk to the mother, what's her anaesthetic or mode of delivery? Make sure you give tranexamic acid, give VT prophylaxis if the platelets are above 50 post-delivery, and active management of the third stage of labour. So she's got a risk of both bleeding and clotting, essentially. But then you also need to think about the risk to the baby. And do you know what I mean by that? How can maternal ITP be a risk to the baby? Do you know?
So I imagine this has to do with maternal antibodies crossing the placenta and becoming an issue for the baby, especially if, you know, the baby's going to have a rough ride on the way out. The last thing you want is them to be a little bit unclotty. Absolutely.
Yeah, absolutely. So we call this neonatal autoimmune thrombocytopenia. And it's basically, there's about 10% risk of thrombocytopenia in a baby born from a mother with ITP, as you say, because of transplacental passage of the maternal platelet or antibodies, which then act on the neonate's platelets. And so the neonate's platelets will typically nadir day 3 to 5 when the neonatal spleen develops. And then by day 7, they will then recover as the antibody is cleared by the spleen and the baby's bone marrow kicks in and makes more platelets. So it's a transient thing, because obviously the antibodies aren't being made by the baby, they're being made by the mother. And so it's short-lived, but it's transient at a time where, as you say, they've just been squeezed through a birth canal. So risk of intracranial hemorrhage is about 1% in these affected neonates, which is much lower than neonatal alloimmune thrombocytopenia, which is a different condition we'll talk about in a different podcast. But things that you need to think about are, firstly, making sure that you take hemostatic measures for the neonate, so avoid Von 2s, forceps delivery, and scalp electrodes for any baby born from a maternal ITP patient. And then also you do a sample of the cord blood and take a full blood count. And if the platelets are less than 100, then they need a daily full blood count to track that nadir. If the platelets are less than 50, then the patient needs an ultrasound scan of their head, the baby, to look for intracranial hemorrhage. And if the platelets are less than 30, then you're going to want to give IVIG to the neonate when they're born, plus or minus platelets if there's any evidence of bleeding. So always think risk to the mother, risk to the baby, and you'll cover most bases.
And I can see why you want an MDT for this. That's absolutely there's a lot going on, isn't it? And having a plan makes that viable.
Yeah,
being reactive to that would be absolutely hellish.
Yeah, exactly. And finally, I think we should talk about ITP in childhood, only because there are some key differences. And obviously, you know, I'm not a pediatric haematology trainee, but most haematology registrars, when they're doing the blood film queue, for example, will come across a low platelet count in a child, and will need to know a little bit about it to be able to sort of signpost the pediatricians. So some of the key differences between adults and children are that we really, really try not to treat childhood ITP. And 97% of these patients are asymptomatic. So it just goes to show how little bleeding they get. And you try to manage them as an outpatient, even if their platelets are less than 20, because kids don't like being in hospital, and because their rate of bleeding is really quite low. And usually they only get skin manifestations, so a petechial rash, which leads to a full blood count, and that's about it. That's not to say that they can't bleed, obviously, but it's just not the norm. And the other thing to say is that 80% of these patients can be managed without any treatment as well. So that's the other thing to say, and that it will most of the time spontaneously regress. It's usually after a viral infection that they develop this ITP. The investigations are a bit different. So baseline immunoglobulins should be checked to think about things like common variable immunodeficiency. Look at the mean platelet volume and think about inherited platelet disorders earlier than you would in adults. And think about autoimmune hemolytic anemia, which can occur side by side with ITP in children. And obviously you won't need to be doing so much of a history and exam for things like alcohol. You generally don't need to do anything until sort of 3 months. And if you hit the point of 3 months and the patient's still got a thrombocytopenia, what we would describe as a persistent childhood ITP, then you need to start thinking about viral screen, H. pylori, autoimmune screen, and also thinking, sadly, about doing a bone marrow biopsy for things like acute lymphocytic leukemia. The last big difference between adults and children in ITP is that if you do need to treat in the event of significant bleeding in a child, then the dose of steroids is higher at 2 to 4 milligrams per kilogram daily rather than 1 milligram per kilogram in adults, and shorter. So aim for a less than 7-day course and avoid dexamethasone. So you're going to go for prednisolone, 2 to 4 milligrams per kilogram per day for less than 7 days, because you just don't want kids on steroids for too long.
Yeah, gotcha.
Okay, so that's it. That's
lovely. That's there's a lot to ITP.
Yeah.
Can you sum up your golden nuggets? 3 would be grand.
Okay.
And so we can take towards our exam prep.
Sure. So I would say first, ITP is a diagnosis of exclusion. Okay. So remember, always think about your differential of a low platelet count and always look at a blood film and think, is my patient sick or not sick? And that will help you to think about the potential cause for the low platelet count. Secondly, is if you've got a bleeding ITP patient, then your treatment options are IVIG, steroids, and platelets, bearing in mind that platelets aren't that useful, and that's important to educate other people looking after the patient around you, like the nurses. In a non-emergency situation, you have a choice, first line, of either prednisolone for 2 weeks or dexamethasone for 4 days. And if it's not working, get them off the steroids as quickly as possible over a week. And many will go on to relapse or not respond. And in those patients, it's about going to TPO receptor agonists more and more these days, rather than rituximab or immunosuppression like mycophenolate. And finally, I would say that switching between TPO receptor agonists is actually something that does work third line in about 50% of patients. And I think that's really interesting. So don't lose hope if your patient hasn't responded to the first TPO receptor agonist, because they may well still respond to a different one. And I think going into the future, it's a really exciting area of haematology, as is a lot of haematology, but particularly just trying to identify what is the underlying disease process in each patient is going to be a key priority to allow us to target this disease better and in individuals in the future. So yeah.
Right. Thank you.
All right. I'll see you next time. Thanks again for listening to Basics to Brilliance Haematology Podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time.